infusing a school support team with a collaborative care model could help overcome barriers in a number of ways, as proposed by the authors, which include use of digital communication and coordination tools. So we need technical and non-human infrastructure, communication infrastructure, shared documentation infrastructure to make a collaborative care model work, facilitating and tracking student referrals. So again, we need both human infrastructure and workflow. I'm sorry, we need humans. We need staffing support as well as workflow and process infrastructure for things like facilitating and tracking student referrals. Developing shared care plans that include behavioral and educational goals. So just what we've talked about with the primary care model, what really makes things not just collaborative and integrated, but also person, patient, client centered, is to have a single share plan that revolves around, in this case, the student, the individual, as opposed to revolving around a department or even an institution like a specific school, but rather shared care plans that revolve around each individual student that include the behavioral health aspects as well as the educational and academic aspects. And again, so you need, as we said, you need documentation, communication and document sharing infrastructure, technical infrastructure to make this work as well. Routinely monitoring student data and outcomes with feedback to frontline professionals such as teachers. So, so again, the outside of IEPs, which students who are in an IEP or getting services provided via an IEP, outside of those meetings, those team meetings, there's not really both neither a technical nor a workflow structure in place, and at least in my experience, to make sure that there's a continuous feedback loop, not just from the behavioral health specialty staff to the teachers, but also from the teachers back to the specialty care staff. So teachers are one of the things that I think that I really kind of valued when I was doing school social work is the eyes and ears of the teacher. They're the ones that really know what's going on with these students because they're the ones who spend the most time with them. So, so cost, and so as it often is, the challenges in the startup cost for such school programs, and often, as we've talked about again as a recurring theme, that we're often penny wise and pound foolish. In other words, we meaning decision makers are reluctant to invest in this human and non-human infrastructure that's needed up front, without either realizing or being willing to kind of invest in the future. But the truth is that, as with kind of a theme with a lot of the stuff we talk about in this course, that the authors say that there are lots of benefits, both monetary and non-monetary, that in such programs where they've seen where you've had this academic and behavioral healthcare coordination, and particularly when you have a feedback loop between teachers and other teaching assistants and other frontline staff back to the specialty care providers, both academic and health, and then from the specialty care providers back to the teachers, that we see improved attendance, increased retention, and rising graduation rates. Now, those are identified as non-monetary by the authors in the article. I would submit to you that there is monetary aspects to these sorry, I lost my pen to think here, to these outcomes, because particularly graduation rates and student retention can be significant factors in the amount of funding you get at a state and even a federal level. So So some of these outcomes can be, and at least in my mind, considered monetary. And again, knowing that we kind of almost thought when we're wearing our advocacy hat, we almost always have to kind of make sure we have an economic argument as well as a human argument. I would say that there is, you know, where, especially in a time where, and this was pre-COVID too, but perhaps even more so now, increased competition for thinner resources at both the state and federal level for schools. And a lot of political strings tied, especially to federal money. Being able to show increased retention and improved graduation rates can really be monetarily good for a school, as well as is the obvious, the human outcomes and the social work outcomes that we care about. So key in summary, what the authors defined as, quote, key ingredients for successful school adoption of a collaborative care model is student-centered team-based care, population-based care, measurement-based intervention targets, and evidence-based care. So just like we said, student-centered, okay, true integrated care, as we've heard, as I believe, and we've heard from authors on different topics, is what makes it integrated, what makes it collaborative, is that the center of the orbit is the individual, and not the physician, not a setting, not a particular specialty provider. It's the individual, be they client, patient, or student. So it kind of all starts with that. Population-based care, so knowing the community, right? Knowing and having a relationship with the community when we're trying to do any of these things, the better buy-in we can get from the community, the parents, faith leaders, local law enforcement, more kind of the community infrastructure, that specific community infrastructure. The more they're bought into this program, the better the outcomes and the better success rate is going to be. Measurement-based intervention targets and evidence-based care, these things, again, can be critical, not just in producing the human outcomes we're looking for, but being able to turn those human outcomes into ways to solicit and elicit additional funding at local, state, and federal levels.